Okay, so while everybody's coming in, if you guys would put your name and your campus in the chat, I would appreciate it. And I don't know if one person already did that, but do it again because now I'm recording. Yeah, Jessica, put yours back in there, would you? Because I'm recording now. Thanks. Did you guys see, I'll see that announcement from Dean Brown from next term?
Yes.
Everybody make sure they have their name and campus in the chat. That'd be fantastic. All right, let's see, we'll wait about one more minute. I need everybody to have their cameras on, please. Kiana, Shia, please. I need to be able to see everybody too. Casey, I can't see you. Eric, I know you're there, but I can only see your hands. There you are. Hi, Kiana. How was the review for you this morning, Kiana?
Really helpful.
Was it good?
It was.
Did you learn a lot?
I did.
Yeah. Good.
She's not allowing us to unmute.
Gonna mute Emma there. Sonia, can you turn your camera on, please? Shia, can you please turn on your camera? Thank you. Hi, Tawana. Tawana has her Christmas tree up. I'm jealous. Shia, I can't see you. I can only see the ceiling. Trying to get you guys prepared for next term after reading Dean Brown's message. Shia, can you pull the camera down so I can see you, please?
I'll put the camera on me. I'm eating right now. Can I eat first?
Sure.
Thank you.
Sonia, can you turn your camera on, please?
Yes, I will. I'm getting things settled. I'll turn it on in a second.
Okay. All right. So let's at least get going with who we have here. I don't really have everybody here, but let's get going. So we got a lot to cover today. So first and foremost, happy Friday of week 9. Okay. This is a busy week this is 2 busy weeks for you guys, back to back. Okay. This week you have several things due, right? You have your case study, you have a set of NCLEX, and you have your HESI prep, right? And I really hope you guys have been working on your HESI prep throughout the term, so that it's not a blank document going into this week. Otherwise, it's going to be a very time-consuming project. But the other, so that's for this week, and that's plenty. And then next week, you have your vulnerable populations assignment, right? And you have your exam. Okay, there's already been 2 exam reviews given this week. One was Monday. Did anybody attend Dr. Ford's on Monday? I don't think so. And then I had mine this morning. I had 2 students attend that. And I think they found it helpful. I'll be sharing the recording of that later today when I finish up all my meetings and classes. And then I sent you an announcement that there's one more tomorrow night at 6 p.m. Eastern, and that's with Dr. Kershaw. So I would certainly encourage anybody who can get to that to try and get to that. And then you'll have all 3 recordings. I already sent you Dr. Ford's recording from earlier in the week. You'll have mine by the end of today. And then I'll send you Dr. Kershaw's as soon as we can get them. Just get hers as soon as I get hers tomorrow night. Okay. Hi, Marissa. How are you?
I'm good. How you doing today?
Good, good. Thanks for asking. If you could put your name and campus in the chat, that'd be fantastic.
Oh, okay. I'm sorry about that.
Yep. No. That's just for attendance purposes. So first question is, did everybody read, does anybody have any questions about Dean Brown's message about attendance starting in January? It's pretty strict. Have you guys read it? Has anybody read it?
I did.
Yeah.
I read it too. So she said we gotta put our attendance name or something in a different website.
No, we'll be doing that.
Okay.
The faculty will be taking it. You'll have nothing to do with it. There won't be any more attestations.
Okay.
All right. It will be, the faculty will be taking attendance and putting it into the system. It's called Campus View, where we do all our documentation. So we'll be taking care of that. But please read through that going into next term. And hopefully your instructors for next term will go over that with you in week 1 during your orientation. Okay. Any questions about that? Well, I'm going through some content here. If you guys want to pull up your group project, because one of the things we're going to do the second half of this class today is we're going to do our just quick presentations, mini presentations of what you did. And just for all of us to hear what you did. And I liked when I did them last term, I thought they were awesome. I thought you guys presented them in an excellent way. And I think I already told you the group projects were excellent. You guys did a really good job. So what else? Exam 3 next week. I'll open that up. Probably won't open it up till next Thursday. So don't worry about downloading it until right before the exam. Okay, because you'll all be taking it next Friday. If anybody's going to be taking it on campus with a proctor, just please let me know who you are and who your proctor will be, so I can send them the exam information. Okay, I sent you guys a roadmap for the next 3 weeks. Everybody take a chance to read that. It included week 9 information and then HESI information. I've posted do I have any Port St. Lucie students in this class? I don't think so. Everybody, all you guys should have your exam HESI schedule. I provided that in a little spreadsheet to you a few days ago, the updated one as of the 30th. So every campus has a scheduled date. So you need to be reaching out to your campus and schedule your HESI. Has anybody done that yet? Anybody scheduled their HESI yet? I see some nods, yes. Anyway, do that. Let's see, next week is week 10. Just get that done as soon as possible. The schedule is up, so you need to contact your dean or contact your campus and figure out how to get scheduled. As far as I know, everybody in my classes are all doing their HESIs on campus. And then the other thing to remember, just because I had an exam. The other thing to remember is going into exam 3, if you're still using a piece of paper or even a piece of paper with a cover on it, you're not going to be allowed to take your HESI. Okay, you have to have a whiteboard to take your HESI. They're not going to allow you to take it. So go to the dollar store or go somewhere and pick up a whiteboard. Okay. We've been supposed to be using whiteboards all term, which I really haven't. I've just been simply encouraging you with each exam. So if you don't have a whiteboard by exam 3 next week, you got to have one by HESI, which is the following week. Okay. So everybody please get a whiteboard. I'm sure most of you do. So, all right. Any questions? So for a few of my students, they've already heard some of the week 9 content because they went to my review this morning. So I did the review for week 7, 8, and 9. And I'm going to go through the content from the book. Okay. We are, what are we covering today? We're covering culture, we're covering ethics, and we are covering some shock, trauma. What do we do? Okay, what do we do in those scenarios? So does anybody have any questions about anything I just went through? Okay, so if you want to follow along with me, I'm going to share my screen and go into the book. Oh, I'm going to be adjusting one of the questions in the quiz that was incorrect. All right, so you'll see that I'll do that over the weekend. So you'll see if you got it wrong, you'll get it right. It was a question about the pregnant mom getting the rubella shot. Okay, because I know you guys have been taught that pregnant mothers don't get the rubella shot. Okay, so I will adjust that quiz question for everybody. Okay. All right. So if you're following along with me, let's go to chapter 45. Okay, so you're only asked to, actually, I'm going to go through this rather quickly because I do want to pull up the study guide and show you that as well. It's not an exam review, but I want to give you some tips about the study guide. Okay, so when you look at chapter 45, your responsibility is pages 1048 through 1054. You're not responsible for the whole chapter. So you need to be mindful when if you look at the study guide, which I think I might have pulled up here. Yeah, if you look at the study guide, I have copy and pasted all the readings, week 7, week 8, week 9. Okay, so we're in week 9. Okay, so it does say chapter 45, but it only gives you specific pages. Okay, chapter 3, there's 3 pages. Chapter 14, there's about 10 pages. Okay, so just because you see the whole chapter listed here, please read further. There's specific pages that need to be covered. Okay, and that's where students get into the issue of overstudying. You know, if they're only supposed to know 4 pages in chapter 45 and they're reading the whole chapter, that's just going to make things much more confusing. So please be mindful. There are a few chapters that it says the whole chapter, but most of the chapters in this class are certain pages from each chapter. All right, so I'm going to skip to what we're expected to know from this chapter. Okay, and this chapter is care of patients with emergent conditions, trauma, and shock. So what do we want to, what do we need you to know from this chapter? Okay, we're going to focus on prevention. Okay, we do know that accidents in the home and the community are the 6th leading cause of death of all age groups. Okay, it's typically kids younger than 5 or elderly older than 65 that are usually the victims of accidents or fatal mishaps occurring in the home, right? So attention to home safety for the very young and the very old may prevent this, or may help prevent these accidents, injuries, or fatalities. Okay, and part of our role in the community setting, a lot of our role in the community setting is primary prevention. Okay, so it's education on preventing things. Okay, and let me remind you, going into exam 3 and the HESI, because this came up this morning in my review, one of the students brought up that not everything that's on the exam I've covered. Well, that's correct, because as I explained at the beginning of the term, there's a reason that this class is at the end of your curriculum. Can you guys help me articulate why that is so? Why is this class at the end of your curriculum?
Let's go over everything we done went through already.
Hey, yep. What classes are we pulling from?
Med surg, maternity, peds. I guess some
Geriatric?
pharmacology too.
Yeah. Fundamentals? Yeah.
Yeah, foundation. Yeah, fundamentals.
Yeah. There's a whole set, week 8 on exam 3, the whole week 8 it's med surg. It's conditions, diseases that you've learned about in med surg. So now we're taking all that information, and let's say specifically with chapter 8, all those diseases, chronic diseases, conditions, now we're taking that patient out of the hospital setting. And how do we care for a patient with cirrhosis, with hypertension, with how do we care for the patient in the community setting, which is the home setting or the long-term care facility, right? So that's how you're bringing everything forward now. You're playing everything forward. So yes, there may be questions you see on the exam or see information in the study guide that you say, she didn't cover that. Well, I didn't cover that specifically, but I've certainly covered the concept. Okay, but you have to be able to bring all the information forward that you've learned from previous classes. This is pulling everything together. Now we're caring for patients in the community. Okay, so let's focus on prevention here. So there's 3 areas, and you'll see, I want to show you this, and I didn't have this morning. So we're on pages 148. So if you look at the study guide, just make a note of this. Let me share my screen here. Where are you guys? Let me share my screen. On the study guide, at the very end of the study guide, it says, Prevention of Accidents, chapter 45. Review this section in the book. Okay, this is what we're talking about. So I'm just going to add this in here so I know what it is. But so if you would just make a note that when you get to your study guide, this is when it says review home safety, highway safety, water safety. This is what we're reviewing right now. Okay, so how do you prevent accidents, injuries, fatalities in the kitchen? Okay, here's 2, 4, 6 examples. Okay, and you are going to get asked about home, highway, and water safety on the exam. So you need to review these sections. Okay, so here's some kitchen safety tips. Okay, specific kitchen, this is for the home. So it gives specific kitchen safety tips, maybe the storage area safety tips, right? Keeping all cellars, attics, garages neat, right? Label poisonous compounds, so you need to know these. And then your living room. Some safety tips for your living room. Cover electrical sockets. Pad sharp edges of the furniture. And then the furnace. Right? This is part of your teaching with families in the community. Have your furnace checked every year. In the bathroom. Bedroom. Your stairways. And these are common sense safety tips. but you need to review them. And this is for the home. And in general areas, install smoke and carbon monoxide alarms throughout the house. Make sure candles are away from flammable materials. We're not saying that candles are not safe, but you need to be mindful of them. Never leave a candle lit unattended. So we're not saying don't use candles. We're just giving a couple of safety tips with regards to candles. And then highway safety. Okay, we know that thousands of people in the US are killed in car accidents every year. In addition, an approximate additional 2 million people are injured. And statistics suggest that improper driving is responsible for almost 90% of all accidents and caused by the influence of alcohol or drugs, distractions, texting, fatigue, speed. Okay, part of our teaching is the emphasis on seatbelts. Okay, so a couple of things. If we're teaching about highway safety, we have an emphasis on seatbelts. That's number one. We should have better enforcement laws against impaired driving. A lot of states now are cell phone free. You can't be driving using your cell phone. Okay, so there's three areas of teaching we can take into account when we're educating families on highway safety. And then we have water safety. Okay, what's water safety? Swimming areas, pools, lakes, anywhere that your people are swimming in water. All right, diving accidents. Okay. About 10 people every day die of unintentional drownings. And this is it. Let's read this. This is really important. The victim of a diving injury should not be removed from the water until EMS has arrived. Because why? Possible neck or spinal cord injury. Right? So people, bystanders who are going to help, need to get in the water and immobilize the head and neck, trying to keep the victim's face out of the water. The only time you pull a victim like this out of the water is if the victim's not breathing, and rescue breathing cannot be performed in the water. You have to take them out of the water and start the rescue breathing out of the water. Okay, and you may need to start CPR. If they have an accident and they are breathing, try and place them on their side in the water. Place them on their side with their head out of the water if they are breathing. Okay? Do you guys know about the Good Samaritan law? What's a Good Samaritan law? You guys got to know this. What's a Good Samaritan law?
If you hurt somebody while trying to rescue them, you're not responsible or liable, right? Something to that effect.
Correct. Correct. Has anybody ever been in a situation they've had to jump in and assist with a patient or a client who has had a traumatic injury or drowning or whatever? Anybody been involved in this? Or an accident on the highway where you stopped? Nobody? Okay. So that's all that needs to be reviewed in this chapter. Okay, pages 1048 to 1054. Let's jump to page chapter 3. Okay, chapter 3 is legal and ethical aspects of nursing. And we're responsible for 3 pages in here, 35, 38, and 41. So let's see what we need to know. Okay. 35. Hang on a minute. Okay. So we're talking about ethics in nursing. All right. So this box 3.2 talks about the partnership between us, the healthcare provider, and the client. Okay. Patients need to understand that the staff is committed to working with them and the family to meet their healthcare needs. Right? We want to provide them the same kind of care and attention that we would expect us and our families to receive. So here's a few bullets of what the patients can expect during your hospital stay. Remember ethics, remember the ethical principles, beneficence. What's beneficence? Do good, right? Remember non-malfeasance, do no harm, right? Remember autonomy. We want to involve the patient in their decision-making for their plan of care as long as they are competent, right? And the fourth ethical principle is, distributive justice. Do you remember what that means? What does that mean? Pardon me? Distributive justice, meaning everybody should expect the same kind of care. No group should receive better care than another group. No group should receive better access than another group. Everybody should receive the same quality. Okay? So think about those ethical principles when we're looking at what patients or you or your family members should expect when they're in the hospital. Or let's take this into the community when you go into their home to do a home visit. High quality care, clean and safe environment, involved in your care, discussing your medical condition and information about treatment choices. That's your autonomy. That's your ethical principle of autonomy. Discussing your treatment plan. That's autonomy. Understanding your healthcare goals and values. Understanding who should make decisions when you cannot. Protection of your privacy, helping preparing your family when you leave the hospital, and helping with your bill and your insurance claims. Those of all the services clients expect of us, as we would expect if it were us or our family member in the hospital. Do good, do no harm. Okay? Okay, this is on your study guide. HIPAA. What's HIPAA? You guys know, we all should know about HIPAA. We should be very versed in HIPAA. What is HIPAA?
The Privacy and Confidentiality Act.
Pardon me? Privacy what? Tawana?
Can you hear me?
I can hear you.
Okay, the Privacy and Confidentiality Act.
Yeah.
Like,
Of information. Yeah. Right. So it stands for the Health Insurance Portability and Accountability Act. Okay. And it has 6 patient rights. Okay. And I should actually, hang tight. I think I want to put that in. Hang on a minute. I think I want to put that in one. I think I want to put that box in my study guide. Oh, no. I'll go back and do that. I gotta remember to do that. So there's 6 patient rights that you need to be aware of. You're going to get asked about HIPAA on the exam. Okay. So the patient rights and the provider's responsibilities include consent. We have to get consent that the patient or the client agrees that we can disclose their information for treatment, payment, or operations. So for example, I used to be in the Kaiser system, had numerous docs, dermatologist, oncologist, surgeon, breast surgeon, radiation oncologist, and a whole bunch of doctors. I gave permission for that information to be shared across the board. Right. So they could be looking in my chart about what happened when I went for radiation. And then my oncologist could look at what the results of that were. Okay, but I had to give permission. Is there any place you go now in a healthcare setting that you don't have to sign HIPAA paperwork? You're always signing HIPAA paperwork, are you not? All right, so I have to give consent for my information to be shared. Okay, notice. Okay, and this is related to the provider. Okay, so the provider must include the 6 patient rights and responsibilities of the provider. Okay, they must talk to the patient about these 6 patient rights. So it's giving notice. That's what you're signing when you go to, that's the paperwork you sign when you go to your doctor's office or your hospital or your urgent care. The provider is getting your permission to share information. Access, right? The patient always has the right to access their medical record. And the patient always has the right to amend their record for the purpose of accuracy. Accounting for disclosures, right? What this means is that providers are held accountable for how a patient's medical information is handled. You know, you've seen stories in the news where maybe a celebrity is in the hospital and people access their chart that aren't supposed to be, right? And then restriction or disclosure. So the patient can request that a provider restrict the use of disclosure of their information. Okay, so please know what these rights are. These patient rights covered under HIPAA. Consent, notice, access, amendment, accounting for disclosures, and restrictions. Okay, and then the last part of what I want to cover, and this is in your study guide as well, this is negligence and malpractice. Okay, negligence is failing to meet the standard of care. Failing to do something sensible, common sense, and careful that anybody else in our situation would do. Okay, so you fail to meet that standard of care. Okay, so negligence for purposes of definition is failing to meet the standard of care, failing to do something that is reasonable and prudent, that a reasonable and prudent person would do, or something reasonable or prudent person would not do. Okay, malpractice is simply negligence by a professional person. Okay, you're not acting in accordance with your professional standards or your scope of care. Okay, as a reasonable, prudent person would. Okay, example of nursing malpractice would be if a nurse didn't check the patient's vital signs and condition after a surgery, and there was a hemorrhage and the patient died. Or inaccurate falsifying a medical record was something you did that you really didn't do. Okay, there's 4, and I said this incorrectly in the review this morning. Okay, there's 4 elements of malpractice that must be present. In the review this morning, I talked about breach of duty, causation, and injury. What I failed to mention was duty. The first one is duty, which is we have a duty to perform in our scope, within our scope of practice. We have a duty to provide reasonable and prudent care. Okay. The next one is breach of duty. We have breached our duty. Okay, we have not provided care as a reasonable and prudent person would. Causation, whatever the cause is that you breach that duty. And then injury, it has to be injury to the patient. Injury or death. Okay. If one of these 4 are not present, the nurse is not guilty of malpractice. So here's an example. If a nurse made a clinical error that did not result in harm to the patient, the situation wouldn't be considered malpractice. However, it would be a deviation from the standard of care, the scope of practice, and could be grounds for discipline, right? By your employer or the licensing board. Does that make sense? So what's important to know here is 4 elements need to be proven. You had a duty to do good. You breached that duty. There was a cause of why you breached that duty, and it caused injury to the patient. And box 3.6 explains those 4. Okay. So have a look at that. All right, and that's all we need to cover in that chapter. And then we jump to chapter 14. Which is cultural. Whoops. Cultural and spiritual aspects of patient care. So this is kind of my favorite part of teaching, and both of these, both the RN and the PN class. Tell me what cultural and spiritual aspects of patient care are and why they're important. Let's start with spiritual aspects. Why is that important in patient care?
Because everybody has different religions and not everybody believes in the same thing.
Wonderful. Anybody want to add to that? For a certain group of clients, applying the spiritual aspect of patient care is extremely important to them. I mean, think about we talked about, but think about the faith-based nurse. What's the responsibility of the faith-based nurse? What does she add to patient care in the community? The faith-based nurse. What aspect does she add that is not always added? The spiritual aspect, right? And so we'll talk about the difference between spirituality and religiosity in this chapter. Okay, cultural. We are taking care of so many different patients from so many different cultures. Okay, it is the expectation of our employer, of the patient, even of ourselves, that we are culturally competent.
The functional integrity
What is cultural competent? What does cultural competence mean?
Being aware of your own religion so that you can relate to others and be non-judgmental.
Yeah. How do you develop cultural competence?
First of all, you have to understand your own religion.
Or your own values and beliefs about your own
Right.
culture. Right? You have to be able to have an understanding of what your own values and beliefs are. And are you able to take care of clients from different cultures that may have beliefs that you support or don't support? Cultural competence is a lifelong journey. I've been a nurse for almost 40 years. Next May will be 40 years. I am still learning how to be culturally competent. It's an ongoing process. And irregardless of where you're working in your nursing profession, you're going to be working with different cultures. All right, so we'll talk a little bit about how to become culturally competent and what happens if you're culturally incompetent. And let's say you're not knowledgeable about every culture that you take care of, which may be impossible. For me in the schools, I was dealing with lots and lots of different cultures. When there was a new culture, a family that came into the school that had a culture I didn't understand, I simply asked. I simply asked about their culture. It's okay, right? They love to talk about their culture and their cultural beliefs. You know, what do you want us to do when your child comes to the clinic? You know, what can we do? What should we be discouraged from doing? Make sense? It's okay to ask. You don't have to be an expert in every culture. So we are reviewing pages 187 through 189. Okay, which starts here of what is culture. All right, culture is a collection of beliefs, values, assumptions that is shared by a group of people. Okay. It encompasses a variety of learned behaviors, beliefs, attitudes, norms, social conduct, right? It may have a defined worldview. Certain culture may have a defined view of the world versus another culture. Okay. Understand, okay, so this is the religious part, the spiritual aspect of patient care. Religiosity and spirituality are two words that we need to be familiar with. Okay. They're often used interchangeable, but they are still very different concepts. Okay, spirituality it's that deep, subjective kind of overall picture you have of spirituality of life. Okay, it's your relationship to whatever you consider physical, non-physical world and the meaning of one's life. That's the big picture of spirituality. Okay, where religiosity deals with one specific religious belief. So if you belong to a church or a mosque or a temple, that particular congregation practices a certain religion. Okay, so understand the difference between those two. Okay. And there was one. Okay, cultural competence. All right. Involves knowing yourself, examining your own values, attitudes, beliefs, and prejudices. All right. It entails for us as nurses keeping an open mind, trying to see the world from a different cultural perspective. What are some barriers to cultural competence? And this could apply to you or a teammate or a coworker. And I'm sure you've all witnessed barriers to cultural competence. Some of those barriers are stereotyping. Everybody know what the word stereotyping means? You should. Prejudice. These are barriers. Stereotyping, prejudice, ethnocentrism, believing your culture is superior to somebody else's. Cultural imposition, trying to trying to force your beliefs on somebody else. And cultural conflict is something that we're going to experience throughout our nursing careers. You can't avoid it. All right. They're misunderstandings of expectations when the nurses are they're not able to respond appropriately to an individual's cultural practice. A lot of times that happens because of a lack of communication. All right. It's okay to ask, right? It's okay to ask about cultural beliefs, cultural values, cultural practices. I think at a hospital of, say, food preferences, and this is in your study guide, certain cultures have different foods they can eat, they cannot eat, how it's prepared, right? Cultural conflicts mostly can be avoided if the patient and the nurse, pardon me, are working in a partnership to both understand. You know, a lot of the cultures that we take care of don't even understand how our healthcare system works. So it's a shared knowledge base of us teaching them how things work in the hospital or the long-term care, and them teaching us about what their practices are. And then if cultural conflict cannot be resolved, it may turn into cultural shock. And that's typically the feeling of helplessness, discomfort, disorientation, right? By us as providers trying to understand or effectively provide care. Okay. So recognize that there are ways to be culturally competent, but there's also a lot of barriers. Okay. Some cultural differences can include communication, the way different cultures communicate, their view of time. Some cultures are past-oriented, present-oriented, future-oriented. So if you have a culture that is past-oriented and you're trying to work with them on future goals, that may be a struggle, and they may need some help with that. Right? If you have a culture that is present focused and you're asking them to participate in a long-term care plan over the next 6 months, they may need some help with that. Does that make sense? So here's some things we consider, and this is summarized in your study guide. Some of the differences, some of the cultural differences we're going to experience that we need to be able to work with the patients, clients with, is communication. You don't need to read through all this. We just need to go through what are some important differences we may have. Communication, maybe a view of time. We just talked about personal space, right? There are some cultures maybe that don't like to be greeted with a hug. Okay, this is a good chart, 14.3. If you want to look at these different cultures and what are some of their common beliefs and practices, really important. Okay, so personal space could be an issue. Maybe family organization and structure is an issue. There are some cultures that like to have their whole family involved in the plan of care. Nutritional practices we talked about. Some cultures eat certain foods, some don't. Some have to have it prepared a certain way. What are their views on death and dying? Wide variations. And then what are their views on healthcare beliefs? Wide variations. So you don't need to know and memorize all this. What you need to be able to do is recognize that cultures are different, and you have to apply your best nursing process during your assessment phase when you're trying to gather all this information, right? Because when you're doing your assessment, you're gathering, how do you feel about this? How do you feel about that? What, do you have any restrictions with regards to food? You know, who's your support team? How do you best want to be cared for? Does that make sense? Okay. I want to be doing that right now. Anybody else? So that is the book content. There's not a lot of content this week. Whoops, somebody's in the waiting room. So does anybody have any questions about those topics? And as you can see, I went to very specific areas of the chapters based on what you were assigned for reading. Okay, these aren't 3 chapters. Let's see, 3 and 14 in the fundamentals book. It's not the whole chapter. It's just what I covered. And when you look at the study guide, let me cover that for a minute, and then we'll go and do some presentations. But if you look at the study guide, whoops, I'm not doing a very good job at sharing my screen here. Everybody see that? Okay, so in the study guide, and this isn't, don't take this as a review. I'm just giving you some strategies, okay, for using your study guide. The study guide has been put together from your lectures, your weekly notes, and your readings. Okay, so your study guide is essentially a summary of the different topics that we've covered over the last 3 weeks and what we feel is important, the most important information pulled out of all of the reading and the notes in the lectures for you to understand these different topics. Okay, so my suggestion would be that you start with the study guide. Okay. If you have an issue with understanding a section in the study guide, please go to here. I've already copy and pasted all your readings. So for example, if you go to the study guide and you don't really understand cirrhosis based on the information I've given in the study guide, go back to your MedSurg book and read those 4 pages on cirrhosis. Okay, if you don't have a good understanding of diabetes type 1 and 2, based on the information that's in the study guide, go back and read that section based on the pages that are listed. You don't need to read the section before, you don't need to read the section after, just that section. And you may have a good understanding of these topics just from the study guide, and that's fine. Okay, but don't overdo it. Okay, this is a very specific study guide. Okay, and then when you're going through the study guide, it's broken out into different sections. So for example, let's think about this. Let's do this. Let's just do a few of them. This section or this part of STDs, we're asking you to know about 5 different STDs. Okay, HIV, chlamydia, syphilis, herpes, and HPV. So let's go back to the first one. HIV, this is the way I want you to read this. What do we want you to know about HIV? We want you to know that it's a 2, 4, 5, these 5 bullets. Okay, so after you read these 5 bullets, then think ahead. Okay, this is the information that we've been given. What kind of questions might we get? So, bloodborne pathogen infections spread through sexual contact, sharing of needles, and vertically through breast milk and pregnancy. Used to be spread through blood transfusions, but blood is now tested with HIV. After needle stick injuries or high-risk exposure, post-exposure prophylaxis is very effective. Those with other other STDs are at high risk for HIV due to traumatized tissue, including chlamydia, syphilis, herpes, gonorrhea. HIV testing is an antibody testing and can cause false negatives for up to 3 months. Testing should be repeated in 3 months. What kind of questions can we get from that? Maybe, how is HIV spread? Well, HIV is spread through sexual contact, sharing of needles, and maybe vertically through breast milk or pregnancy. What are people, why are people, I don't know, I'm thinking out loud. Why are those with sexually transmitted disease at higher risk for HIV? Testing. When do you repeat the test? 3 months, 6 months, 9 months, 12 months. Okay, does that make sense? Let's do the next one. What's chlamydia and gonorrhea? Bacteria spread through sexual contact, treated with antibiotics. Sexual contact should stop until treatment is completed. Can be asymptomatic and cause pelvic inflammatory disease, which can lead to infertility, endometriosis. What are some questions we could gather from that information? If a client has chlamydia or gonorrhea, what are potential complications or further conditions that can be developed from that? What's the answer? Pelvic inflammatory disease. I'm just throwing out questions, but that's how I want you to look at it. You read through each section, and what do you need to know? What's really important that you need to know? Okay. The next section, all the major sections are highlighted in yellow. So that first section is on STDs. The second section, and these are topics that we've covered in class: infection, prevention, and control. Hepatitis, TB, smallpox. What's the difference between smallpox and chickenpox? As far as where you might see sores. It's highlighted. It's highlighted down here because I went through this in my review session.
The soles of the feet.
Okay, soles of the feet. What is chickenpox of the soles of the feet, or is it smallpox?
Isn't it smallpox?
Okay. Did everybody know that? Okay. Here's your foodborne illness and food safety teaching tools, because we're in the infection prevention, control, and spread. So if we're teaching a family about foodborne illness, food safety, here's some examples of what we teach them. Same with waterborne disasters. This is the last section I'm going to go through as far as structure. So let's read about disasters. Well, and it's highlighted because I did this in my review this morning. So there's a lot of information in these 5 bullets. Disasters are labeled natural and man-made. Here's some examples of natural. Here's some examples of man-made. Maybe you get a question on an earthquake. Okay, an earthquake happens somewhere. Is that an example of a natural or a man-made? Okay. Here's what we do for teaching. Water can be considered safe by boiling for 3 to 5 minutes. Treating with household bleach. How much? 1 ml of bleach for a gallon of water, but it must stand for 30 minutes. Removing water from a hot water heater or a commode tank. Maybe you're working with a family and teaching them after a disaster happens. What do you teach? Do you teach that they have to boil water for 30 minutes? Do you teach that you can add 10 mils of bleach in a gallon of water for 30 minutes? No. No, they don't have to boil water for 30 minutes. It's only 3 to 5. Same with a chemical spill. Let's assume a chemical spill has occurred. Well, we know that we use tongs to remove all clothing. Here's 3 different kinds of the common chemical agents: vesicant, nerve, blood. We give you an example of each and show and identify what are the most common complications. So what if you have a question about the client has been exposed to, comes to the ER and has been exposed to mustard gas? What should we expect to see? Ocular, dermal, and respiratory conditions. What if they're exposed to cyanide? What should we expect to see? Skin and respiratory complications. So you getting how to tackle that? Yes or no? That's how I want you to tackle the study guide. God, there's a lot of people I can't see. Cameras are facing ceilings. Chantel, Marissa, Sonia, Brianna, where are all you guys? I can tell you next term, that's not going to fly.
I'm right here.
Okay.
Much as my head is, I'm sorry.
Oh, that's okay. No, but I'm just trying to prepare you guys. Next term, that's not going to fly.
I'm here, but I'm not at
I
home right
see.
now.
Okay.
And where my phone is dead. So where the plug is, I can't sit in front of it.
Okay. I'm not trying to be I'm not trying to be a pain here. I'm just preparing you guys for next term. All these things are going to be in place next term. So that's a quick review of the study guide of how I think you should attack it. Last question. Does anybody have, I have my own, which I share in my reviews, but does anybody have any good test taking strategies that they use that might be helpful for the whole group to hear? Shakia, you don't have any. You're shaking your head no. None? Does anybody have any helpful strategies? I heard a nice helpful strategy a couple of weeks ago from a student that next to every question on the exam is an eyeball, right? Has everybody seen that eyeball? So I have a student, have a student right now. Here's what she does. When she reads the question the first time, she takes her highlighter and highlights any important words or phrases that she picked out of the question. Okay, whether it's priority, what's the first, what's the greatest, what's the last, what's the priority, what's whatever word sticks out. Okay, and she also highlights it if it's a negative question. So if the question, you have the whole question, at the end it says, what is the inappropriate response? Right, that's the negative question. What requires more teaching? What is an inappropriate response? She highlights that part of the question so that when she reads it a second time, it's highlighted. And she takes the line from the eyeball and she scratches out whatever answer is, is not even in the ballpark. I thought that was 2 good suggestions. And I have to tell you that of all the reviews I've done this term, and especially in the last couple of weeks for exam 2, mostly, not many people reached out for exam 1, but a lot of people reached out for exam 2. I can tell you the 2 questions that people are getting wrong. Okay, they're getting the priority questions wrong. They're reading the question too fast. You're not picking up on that key word. Okay, of what is the initial intervention? What is the best intervention? What is the first intervention? What is the greatest? You have to be able to pick up on words like that. If you get to a question and it's not select all that apply and all the answers look correct, then you missed a word somewhere. Make sense? Go back and look at the question and find the word you missed, because it probably says something like first or initial or most. And the other question people are missing is asking it in a negative way. The nurse is observing a new student, teaching a patient, going through patient discharge instructions. What does the nurse say that you know requires more education? What does that question mean? What is she saying that's going to be incorrect that we know she requires more education? Right? This is important. A lot of you guys are missing these questions. So what, does that make sense? All right. You're doing patient teaching with a family and you're trying to encourage, you've gone through all the teaching about the dangers of smoking in the house with kids with asthma. What does the client state to you that you know requires further education? So what kind of answer are you looking for?
I'll just use e-cigarettes.
Okay, great. And what does that mean?
They don't understand what you're saying.
Exactly. Bingo. Do you understand that? So what does the patient say that you know requires further information, further education? Or let's play that the opposite way. What do the patients state that you know she has a good understanding of what you just taught her? That's the difference between positive and negative. Make sense? Let's talk about, this came up in our review this morning. Let's talk about the question from exam 2 about the LGBTQ family is in the clinic. You're trying to do your assessment. What kinds of questions would you ask that don't assume heterosexuality? So what does that question mean?
So like, do you live alone?
Okay, good. What if you asked, and that's, so you're trying not to assume heterosexuality, not trying not to make judgments. What if you said, do you have a wife and kids? Is that assuming heterosexuality? Yeah. What if you said, do you have a girlfriend? Is that assuming heterosexuality? Yeah. What if you say, do you have a partner? Is that good? Well, you're not, yeah, you're not assuming anything. Right? But if you say, do you have a wife and kids? That's making the assumption of heterosexuality. That's not what the question asked. The question asked, what questions do you ask that don't assume that? A lot of people got that wrong. Does that make sense? What was another negative question? I just went through a whole bunch of them. The new nurse. Oh, okay. So you're teaching a family, you're teaching a family member how to do wound care. When they demonstrate back to you how to do the wound care, let's do it positively and negatively. What are you observing for that they understand your teaching? So that would be a positive. They put on gloves, they dispose of the whatever. How about same question, but the final part of the question is, what do you observe them doing on their demonstration that requires the need for further education? They didn't put on gloves. They didn't dispose of the linen or dressing appropriately. Guys understand that? Don't read the questions too fast that you don't pick up on that. Read the question twice. Read it first, either write down on your whiteboard a key word or key phrase, or even write down positive or negative. Because you scratch it out, right? For every question, positive, negative. And it's if a negative, you know you're looking for a wrong answer. Not wrong, you know what I mean. The right answer is going to be something they did wrong. or something that was omitted or something. Okay, have I beat that one up enough? I did. There was just so many questions. That was primarily what you guys missed. You didn't miss prevention questions, primary, secondary, tertiary. You missed priority questions with keywords and negatively asked questions. So that's my quickie exam review. And then I'll send you out the recording of mine from this morning. Watch it because I go through a whole lot more test taking strategies in that. Okay. Okie dokie. So let's do some just group presentations. I'm just talking a couple of minutes. I want you guys to share all these great presentations that you did with the whole team, and make sure everybody's name is in the chat with because I have a lot of people not here today. So who wants to go? I don't care if one person presents or the whole team presents. Pull up your group projects and just give us a summary.
I don't mind going.
Okay, who said that? Erica, you go first.
Oh, okay.
Tell us about who's in your group.
Oh.
Well, okay, I forget that. Go ahead. Just do your presentation.
Sorry. Okay, so we had whooping cough, also known as pertussin. It's when the symptoms of whooping cough are similar to the flu, with its runny nose, fever, but after a week, that's when the persistent cough starts, and then that usually lasts about another 3 weeks. Whooping cough usually goes undiagnosed because people just think they have the flu, so they stay at home. So that's why the CDC, there's not a lot of awareness out there for it. But it's easy. If it's caught within a week, you can easily go to the doctor and he can prescribe either azithromycin, clindamycin, or there's another medication. But if you've had it for at least 3 weeks, the doctor usually won't give you any medication because by that time the bacteria has left your body and you're just dealing with the symptoms.
How is it transmitted?
It's transmitted through droplets, so from coughing or sneezing and being in close proximity with people that are having those symptoms.
And it's contagious.
Yes, ma'am, very contagious.
Very contagious. What else do you guys, I'll add something about what do we think we do with a pertussis when we get into the schools? So that's what I dealt with for 20 years. Do you think it's excludable? Kids have to stay.
Vaccine for it. Once you get the first dose, you don't have to get the next dose for 10 years. But most usually get the vaccine. Yeah, there is a vaccine for whooping.
Yep. And I'll add to that in the schools, pertussis is a reportable disease to the health department.
Right. Yes. Once if you go to the doctors and they do find that you have whooping cough, they do have to report it to the State Department and then they report it to the CDC.
Exactly. Exactly. Anybody else have anything to add to that or have any questions for Erica about whooping cough? Has anybody ever had whooping cough or had a kid with whooping cough? It's pretty nasty. Thanks, Erica. Okay, who else wants to go?
Well, we had whooping cough too. So.
Wait, who's going to go?
Group will go.
Who said that? Who's talking?
We're going to do
Casey.
hepatitis.
Casey, okay. Hi. Casey, who's your group? Who else is your group?
Me, Jessica, Kendall, and Blake.
All right. So anybody, Blake's here.
They're all here.
Everybody's here. Okay.
Yep.
So jump in.
All right, I'll do the first paragraph. Hepatitis, it's an inflammatory condition of the liver Viral infections are the most common cause of hepatitis, but also some medications, heavy alcohol drinking, and other medical conditions can lead to hepatitis. There are 5 main classifications of hepatitis, which are hepatitis A, B, C, D, and E. Diseases that resembled hepatitis A were first reported in China over 5,000 years ago, and a physician named Bloomberg discovered hepatitis B in the 1960s. According to the WHO, it is estimated that 354 million people have hepatitis B and C worldwide.
So hepatitis A and E, they can come from fluid and water that are already infected with both. But B and C can come from bodily fluids like blood or vaginal secretions and semen. Hepatitis D can also come from blood that contains Hep D. Adults ages 30 to 59 are the most affected. It comes from people using and sharing needles from injection drugs, or men who also have sex with men, people that have HIV as well, and homelessness. Asian Americans are at most risk for Hep B and C, B, while Hep C mostly affects African Americans. The Hep B vaccine is recommended for all infants and all children and adolescents younger than the age of 19. Some of the symptoms, the symptoms are about the same for all 5. Liver gets inflamed. It's fatigue, flu-like symptoms, dark urine, pale stool, loss of appetite. Hep B and C may not show any symptoms until the functional liver is already affected. Your liver may be being attacked by the virus. It causes it to be inflamed and can cause severe damage. Hepatitis, to treat it, it's important to know what causes. Hep B can develop cirrhosis, liver failure, cancer, and Hep A can recover with no lasting damage. Treatment varies for each type, or there is no treatment at all, basically. Hep B and A and B are mainly supportive care, rest, adequate nutrition, and hydration. There's meds for Hep B like Vered, Vimeldi, and Zephyrex. Hep D has medication called, however you say that, pegylated interferon, but has severe side effects. And then, so mostly people that have it, it varies. The person would experience, they could extreme fatigue, like I said earlier. So it could be a struggle to do any kind of like daily activities. They may not have an appetite due to it, and they should know to avoid things like shellfish, which can be contaminated with bacteria that's toxic to the liver. A person should practice good hand hygiene, stop drinking, inquire about vaccines, maintain good weight with exercise to boost their immune system.
Awesome. Great. Okay, Kendall, Jessica, do you have anything to add?
Well, I have something to add. So Blake kind of covered the rest of the writing, but some of the patient teaching and family teaching that you should include is also the same for them. Make sure they have adequate hand washing. They know how to wash adequately. Make sure that the environment is kept clean for those people, and they're encouraged to be social due to the limited the limited things that they can do from getting tired or being sick and having those flu-like symptoms. So you want to teach, those things as well to make sure that the patient still able to enjoy, what life they have left with dealing with hepatitis. So.
Awesome. Great. Brittany? No, not Brittany, Jessica, I'm sorry.
My classmates really went over everything. We were supposed to do it in sections, so Blake read the whole thing off.
Good job, Blake. You took Jessica's part. Good job.
I got nervous and just kept going. I'm sorry.
It's okay.
All right. So we covered everything. You guys, that was awesome. Okay, next group. Who's next?
The other group already went over our topic, Ms. Marvel.
Say that again?
This Marissa, we had whooping cough too, but the other group already went over it already.
That's okay.
So you want me to read it over again?
Wait, but which group are you in?
Me, Jor, and Brianna and Normani. We had whooping cough.
No, wait, you, Jordan, Armani, and who?
And Brianna.
Brianna. No, I want you guys to give us a brief synopsis. You may have information that Erica didn't provide.
Okay.
That's okay.
Okay, I don't remember everything she said, but I know like the outbreak started in 1414 in France, and by the 20th century it was the most common childhood disease, and it was also a major cause of childhood mortality. It's highly contagious and it's caused by the bacteria Bordetella pertussis. And once it's attached, the bacteria releases a poisonous toxin which damages the cilia, which causes the problems in the air, makes the airway swell. And it can be transmitted through air. Infants get it coughing from older siblings or relatives or caregivers or anybody. A lot of people don't know they have it a lot of the times. And some of the late symptoms that occur can get coughing, which can last from 1 week, 2 weeks, or even months, like a couple months, not like long months or whatever. Like before, other groups say, you got reported to the CDC, the vaccines, the DTaP and Tdap. Children younger than 7 years old get the DTaP, while older children, adults, we get the Tdap instead.
That's correct.
Basically, the vaccine helped prevent from the coughing and stuff, and we got to report it to the CDC, and we just do breathing monitoring, give them oxygen, preventing dehydration and stuff, and monitoring mucous membranes. That's about it.
Yeah, so there were several things that you presented that Erica didn't, that I learned. Jordan, anything to add? Armani, anything to add?
She covered basically everything.
Okay, so here's a question for you guys, and I just bring in my school experience. What would you do if there was an outbreak of pertussis in your school and you had students that were not vaccinated against pertussis? What would you do? This could be for anybody.
Send them home or isolate them, I guess.
You can send them home, or isolate them.
And you must get with the the school district to report it to the health department.
Correct. Yep, we already know we're reporting it. What would be the very first thing you would do as soon as you found out you had an outbreak? Let's say you had 15 students that were not vaccinated because of either and they had exemptions, parents filled out a personal, religious, medical exemption. You have a couple of kids who are immunocompromised. They have cancer and they're in treatment. What do you do with those families? That's the first thing you would do with those families.
You contact them and you let them know that their child was exposed, regardless of, whether they were vaccinated or not. And then, you give them that option to either pull the child home and care for the child and keep them safe there and continue, or, they interact with the school district or the staff and see how can they move forward with the teaching for their kid.
Kendall, are you a school nurse?
No, I just have a lot of children.
You know about this. So that's exactly right. We always have a short list of parents we're going to call with this kind of an outbreak, a measles outbreak, a serious outbreak, not so much strep throat, but we have our short list. We call those parents first. Okay. And there's always a letter that goes home. Part of the CDC requirements is you have to send a letter home, but we tried to be proactive and at least call these parents. Hey, we have an outbreak of pertussis. We were recommended to tell them that it's best if you keep your child home until this outbreak passes. Okay, because those kind of kids who are non-vaccinated for whatever reason, and we can't question the reason why they're not vaccinated, we can't question that, but we can be proactive with them in suggesting that their kids stay home until it passes. And that happened a lot with pertussis. So great, you guys. Great, great. All right, next group. Let's see. Who do we have?
I think it's just us now.
Okay.
Yes.
Dick Shia, who is your group?
Mackenzie and Leslie.
All right. What'd you guys do?
We did hepatitis.
Okay. Tell us about it.
I'm just trying to see if I can just say Mackenzie's part. It doesn't look like she's there.
She was
'Cause
here.
I just wanted to go in order.
Mackenzie went to the bathroom real quick.
Okay. Okay, I'll just start it off.
Okay.
So hepatitis is a serious infection that causes inflammation in the liver. And she wrote that liver is a vital organ that filters blood, fights infection, metabolizes carbohydrates, fats, proteins, and does much more. So there are 5 types of hepatitis: A, B, C, D, and E. The most common are A, B, and C, as we all know. And hepatitis A is a short-acting illness that comes from contaminated food and water, and even through feces. Hepatitis A was first discovered in the 17th century and was associated with military campaigns. The first outbreak was recorded during 1800s in Norfolk, Virginia. The disease was commonly found in Union troops during the Civil War, with more than 4,000 cases were reported. And hepatitis B is a chronic lifelong infection. It is transmitted through bodily fluids such as blood and semen, or like sexual transmission. And it can be passed from the mother to the baby. Hepatitis C is also a chronic infection. It is transmitted by like the exposure of contaminated needles such as IVs and like blood transfusions and stuff like that. Yeah, so this was the main what hepatitis is.
Okay.
So anyone-
Leslie, you want to add anything?
So treatments for hepatitis A would be 1 vaccine, and then treatments for hepatitis B is 3 vaccines, and then hepatitis C, there's no vaccines for this one, but there is weekly injections.
Mm-hmm. Yeah. Great. Okay. Any questions for the group? Thanks, you guys. Who do we have left?
Me, Chantel, and James.
I'm sorry, who's talking? Tawana?
Tawana. Yeah.
And who's your group?
It was me, Chantel, and James.
Okay. I saw James on here earlier. Is he gone? Okay. Looks like he's gone. Okay, go ahead, Tawana.
So we had Ebola.
Okay.
Ebola is also named as the hemorrhagic fever. It is a deadly infectious disease that mostly occurs in Africa. It was first discovered in 1976 around the Ebola River, which is now the Democratic Republic of Congo. The natural host, is the fruit bats and non-human primates. When a person first contracts Ebola, they experience flu-like symptoms such as fatigue, muscle spasms, headache, dehydration, and sore throat. As it progresses, they exhibit signs of hemorrhage. So the person will become to bleed excessively from the eyes, ears, and gums, even without injury. The patient may also cough and vomit blood. It is transmitted through direct contact with wild animals. It can spread from person to person through contact with blood products, bodily fluids, and contaminated surfaces. Additionally, broken skin and mucous membranes will allow the microorganisms to enter their host. And I think Ms. Chantel was going to read the rest.
Okay, great. Thank you. Go ahead, Chantel.
It is also recommended to avoid large gatherings when you have it, bodily fluids, and contaminated surfaces to control the transmission. Surfaces should be sterilized to 162 degrees to 176 degrees Fahrenheit for 30 minutes will kill the microorganisms. Sexual activity with an infected person should be avoided until cleared by healthcare provider. Early diagnosis includes the chances of survival dramatically. However, it is exceedingly difficult to diagnose because it is initially presented with flu-like symptoms. Confirmation of the virus is by antibody capture enzymes linked immunosorbent assay, the ELISA, antigens captured detection tests, and serum neutralizing tests. Treatment is aimed at supportive care since no cure is available at this time. A blood transfusion and rehydration IV therapy will be given to compensate for fluid loss. Vaccines are now available to protect against Ebola and used to control the spread. In the attempt to monitor and keep tracks of the disease, all confirmed or suspected cases must be reported to the CDC and prevention immediately.
Awesome. Awesome. Anybody have any questions about Ebola? Excellent, excellent. Yeah. Okay, next. Who do we have left?
We had Ebola also.
Go ahead. Is this Danielle?
Yep, it was me, Sonia, Celeste, and Kiesha.
Okay.
I'll start, Danielle, if you want me to.
Well, she pretty much covered everything. The only thing that I needed to add was that there are only 4 known types of Ebola that have infected humans. And then the long-term causes and effects basically says those who recover from Ebola develop antibodies that can last 10 years or more. They're believed to have some type of immunity to the type of Ebola that caused their sickness. It is not known whether they're immune for life or they can be infected with different species of Ebolas. In most cases, people don't become reinfected. And also many people who recover suffer from health issues. Some report tiredness, headache, eye and vision problems, weight gain, and stomach pain. Other health issues include memory loss, neck swelling, chest tightness, hair loss, hearing loss, tingling of the hands and feet, inflammation of the tissue around the heart. And others have reported inflammation of the testes, changes in menstruation, depression, anxiety, and PTSD. Everything else they covered.
Yeah, but no, what you said though is a whole different perspective. So that's good. Yeah. Sonia, anything to add? Everything got covered, Sonia?
Yes, they covered everything.
Okay. I don't see Kiesha anymore. Okay. All right. We should have, the reason why we have a couple of doubles here is because I should have thought of that and I didn't. This is a combined class. It's 2 sections. So yeah. Anyway, but no, I mean, the second group who have presented the same topic have definitely added to the conversation. Okay, who do we have left that I haven't heard from? Emma, who's your group?
I have Brittany.
Okay. Who else?
Danielle and Latrice.
And Latrice is in here.
Yeah.
Let's see, Danielle's here. No. Is there other Danielle here? I thought she was.
No, she's not here anymore.
No, she's not here. Latrice isn't here. Brittany, she's here. There's Brittany. What'd you guys do? You and Brittany.
HIV.
Okay, tell us about it.
I know some risk factor of HIV are unprotected sex, which can be oral, vaginal, or anal. And then you can also contract HIV by sharing needles and syringes with an HIV infected person. also through maternal fetal exposure. And then the new thing I learned, and I think was yesterday, was that there are two types of HIV, type 1 and type 2. HIV type 1 is predominant in Eastern area, and the type 2 is mostly in West Africa. And then they say the type 2 is less, I would say, contagious. Okay, now I'll let Brittany say.
Hang on, before Brittany goes, I didn't know there were two types of HIV. Did you guys?
Me neither.
Did you guys? I did not know that. I did not know that.
I just found out yesterday.
And how did you find out? Where'd you get the information?
Okay, let me try to find it out and I'll forward it to you.
Yeah, forward it to me. I had no idea. No idea. Okay, Brittany. Come on, Brittany, you're up. You're on mute if you're talking. Brittany. There you are.
I guess I would like the signs and symptoms of, or the patho of HIV is a retrovirus which attacks the CD4 T lymphocytes, eventually leading to the death of these cells and serve immunodeficiency of the individual who have acquired the infection. Once the CD4 count becomes too low, the host immune defense cannot fend off opportunist infections and I can't say that word. Symptoms for HIV is flu-like symptoms, which can include fevers, chills, rash, night sweats, muscle aches, sore throats, swollen lymph nodes, mouth ulcers. Some symptoms can last anywhere from a few days to several weeks. Some people do not have any symptoms at all during the early stage of HIV. The only way to know if you have HIV is to get tested. Treatment for it, there's no cure for HIV, but you can slow the progression of the disease with HIV treatment. Antiviral therapies. ART is the treatment for HIV. ART involves taking a combination of medications and following an HIV treatment regimen every day. The main goal for treatment of HIV is to reduce a person's viral load to become undetectable, slowing the growth of the virus as well, trying to improve the immune system. Being undetectable means that levels of HIV in the blood is too low to be detected by a viral load test. People who maintain an undetectable viral load have no risk of transmitting HIV to their partners.
Awesome. Awesome. That's great. No, that's great. I mean, HIV, I mean, it's really a lifelong of symptom management. Right. Awesome. Did I forget anybody?
No, but I found where it says that there were two different types of HIV.
Where?
It's on healthline.com. It says there's HIV 1 and HIV 2.
So put the link in the chat.
HIV 2 is mainly found on West. Yep.
Yeah, put the link in the chat. I'd be interested to read about that. Great job, guys. Great, great, great. Really proud of you. Did you enjoy the group project? Sometimes group projects can be hard if everybody's not participating or people aren't communicating. But the reason why we do a group project is twofold. One is, as a nurse, you're going to be working, well, as a nurse, communication is key. You're going to be communicating with all different kinds of people on all different kinds of teams, right? And number two, when you're functioning on a team or in a group, whether it's setting up an educational program, whether it's discharge planning, you know, if you're a case manager and you're having to coordinate care, this is all group teamwork and it involves communication. So most of the teams didn't have any issues. I had a couple of teams that had some issues with response times and communication, and tried to work with those teams to talk about group dynamics. All right. Because you're going to be part of groups your whole nursing career, and not everybody's going to be an active participant. Right. So how do you recognize when they're not, your team members aren't active participants, or they're not carrying their load, or they're not participating? How do you deal with that? Because you're going to be dealing with that. So that's the reason we try. And I know you've worked in groups, and you probably have study groups, and you've worked in groups your whole time at Fortis, but you're going to be working in groups and teams and communicating with many, many, many different people in your jobs. So yeah. All right, let's everybody pull up their week 9 attestation, and then we'll be done. I'm going to pull it up too here. Oops. Week 9 attestation. All right. Okay. Again, questions 1 and 4 are the same. You attended lecture on 12/2 with me. Okay. We talked about this. What's the good, number 2, what's the Good Samaritan law? Somebody had a really good description of it. Blake, was that you?
Yeah, it's just a law that protects you from legal persecution if you try to help save somebody's life and you accidentally injure them.
Okay, Blake, will you put that in the chat, please?
Yes, ma'am.
Thank you. Then you can copy that into your question 2 box. Excellent answer. Don't ever be afraid to jump in and help. Don't ever be afraid to jump in and help. If you are capable, willing, and able. So Blake's got to put that in the chat for us. And then our next question is the difference between religiosity and spirituality. But let's do this question first and get it in our. There you go. Okay, difference between religiosity and spirituality. What's the answer? One is very specific, one is very general. Who wants to lead the way? Anyone? We just went through it, so anybody have any recollection of what we went through?
Religiosity is very specific to one religion, and spirituality is like as a whole, like more than one.
Your worldview.
Yeah.
Religiosity is focused on one religion, right? One religion. So it's whatever, let's say you belong to a church or a mosque or a temple or a whatever. It's whatever that you're practicing. Whatever you're practicing is your religion. focuses on one religion. Where your spiritual view is kind of your big picture thinking process about the spiritual nature of your being, of the world being. Make sense? And then just to submit when you're done. How are you guys coming on your HESIs? Anybody? Few of
It's
you.
coming along okay.
Okay. I just hope nobody has a blank document right now. And really what I just want is a brief description of what the topic is. I think I put some specific directions in there. Really my purpose is making sure you have an understanding of each of those topics. Okay, because each of those topics is covered on the HESI. I told you at the beginning of the term that HESI prep packet was developed from reviewing previous HESIs. So over the last couple of terms, when you guys do remediation, I can see the topics that you're needing to remediate. Okay, so I don't know the questions on the HESI. They don't come from, we develop the exams, but HESI comes from a big bank like NCLEX. But I can see the topics that are covered. And those topics are listed on your HESI prep. Right, so if it says disaster, and it says, I think one of the items in disaster, it might be red tag or something about tags. What does that tell you? That tells you that we have to have an understanding of how they tag in disasters. I don't know what the question is, but there was a question about tagging. Make sense? So that's the way you need to think of your HESI. Each box is, okay, there was a question about this topic. What should we know? Okay.
I have something to say. I didn't notice that I was doing the wrong HESI prep until yesterday. Because I was doing the one that's posted in week 9, but I guess you sent one in the announcements or something.
Yep, I sent, I way back when you guys
Right,
got that.
so I need to fix that.
Yeah, way back when I said, please ignore the HESI 9, you take that out. Please ignore week 9 HESI. Here's the revised one. I
It
want you
doesn't,
to do.
yeah, which is, I understand that you made a post about it, but it just makes a lot of confusion.
Well, what's the confusion if I posted
It should be taken out of week 9.
Right. But that's a curriculum change, and that's why I explained, ignore it. It will be taken out for next term, but I can't have it taken out once the term is started. It's part of the module. So, yeah, okay, but thank you for bringing that up. I appreciate it. Anybody else have any questions? All right, well, I hope you guys have a good weekend. Reach out if you need anything. And as always, before your exam next week, if you go through and do all your due diligence with studying and preparing, and there's still aspects of the study guide you're not getting, you're not comprehending, please set up a meeting with me next week, a tutoring session, and we'll go through it. Okay? All right. I'll stay on for any questions. Otherwise, have a great weekend. Happy Friday. Emma, do you have any questions? Danielle?